weekend for us. We really appreciate that. Today's webinar is about vitreolysis, a process for removal of vitreoretinal floaters using a specialized YAG laser. With us today, time on here for us. We really appreciate that. Today's webinar is about vitreolysis, a process for removal of vitreoretinal. Today with us is Dr. Inder Singh. He's the president of multiple large ophthalmic setups in Wisconsin, USA, and Dr. Amitava Biswas, our friend and KOL and a very prestigious doctor from Calcutta. He heads the Sunetra Family Eye Care Center in Kolkata. Am I audible?
Yes.
Okay.
Yeah.
Dr. Paul Singh has trained in prestigious institutions like Duke's University. Over a span of 15 years, he has taken leadership in exploring and establishing several new techniques internationally. Floater removal with a specialized laser is one of them. With 6,000 plus patients treated with this technology, he has not only perfected the technique, but has helped tremendously in developing protocols for its efficacy and safety. Besides being a dedicated ophthalmologist, there is another amazing facet to him. He is a passionate musician. He has been a lead in one of the bands in USA for the last 20 years. And so much is his love for writing and playing music that he has created a studio within his home for audiovisual making and perfecting and practicing. So we have with us a very interesting person, a very knowledgeable person in Dr. Inder Singh. Dr. Inder Singh Paul, thank you very much for being with us and very welcome on this webinar. Dr. Biswas, thank you for coming. Thank you for being part of us. He is heading one of the finest and most modern hospitals for eye care in the eastern part of Calcutta and perhaps India too. He has studied and has been consultant in institutes like CMC Vellore, AIMS Delhi, Shankar Nethralaya, Yale Eye Center US, and many more. Made a mark with his pioneering spirit and his noble nature. His forays into community ophthalmic service are very well known and highly lauded. His zeal for equipping himself with the latest technologies put him in a distinct class of operating surgeons in India. For vitreolysis procedure, he has been the first in India to pioneer this, learn this. He is passionate about retinal imaging, and perhaps from there stems his other passion, photography. He is a very, very passionate photographer. His friends wake up every morning with a greeting from him, accompanied by amazing shots captured on his lens. Blooming flowers never looked as good as through his cameras. I have been one of the lucky participants and recipients of his greetings in the morning. So it is my special pleasure and privilege to have you with us, Dr. Biswas. Thank you for being here today.
Thank you.
With this, without much ado, I hand it over to Dr. Paul Singh to take the webinar further. Thank you.
Thank you for that beautiful introduction, Shanaz. I appreciate the opportunity to be here with everybody. Thank you also to Amitava, Dr. Biswas, for allowing me to join him in this presentation as well. And thank you all in India for letting me speak to you. I'm here in the United States. It's early morning, 7 o'clock in the morning. So good morning to everybody and good evening. We are excited to be here and excited to talk to you about a extremely exciting technology and a procedure that I have adopted and truly has revolutionized my practice. But before we start talking about laser floater treatment and vitreolysis, I wanted to get you engaged, and I wanted to get an idea of kind of where the perception is out there, and what's the adoption so far in India. So we have a couple questions, a couple polling questions that we wanted to ask first before we get started. So if we want to go ahead and bring those polling questions up, we can ask the audience a few questions to get started.
Right. Sachin.
All right, so we have a couple polls we'd love to have you click on. The first question is, which treatment are you currently using to treat vitreous floaters? Laser floater removal, vitrectomy, or just ask the patient to just live with it? Give you a few minutes, a few seconds to click on those buttons. The second question is, do you believe that vitreous floater treatment can be done with all conventional YAG lasers? Meaning, can any laser, any YAG laser, successfully treat all vitreous floaters? Yes or no? And the last question, do you think laser floater removal can cause adverse events such as retinal detachment, or residual floaters, pressure spikes, or all of the above? So we'll give you a few more seconds to answer those questions, and we'd love to hear or see the results in a few seconds. Dr. Biswas, what do you think while we're waiting for the poll? You feel like there's a skepticism out there amongst all of our peers around the world on laser floater treatment?
Well, I was first introduced to this machine at one of our All India ophthalmic conferences at the Toshbro booth. And I was amazed with the application and the amount of the ease with which we can perform vitreolysis for floaters, which is a very common symptom in many patients. And so I took to it, and within a short time we had placed an order, and I started using it. And I was very thankful that it's a very good and simple, effective method for removing bothersome floaters.
Yes, exactly. And I think for me, there's definitely some skepticism, no doubt about it. But I believe that for me personally, it's been a change in terms of my appreciation for how much of an impact floaters can have on patients' quality of life. Until I started performing laser vitreolysis, I don't think I appreciated how much of an impact it can have on patients' satisfaction and quality of life. Let me share my screen real quick here, and we'll get the slide deck up here. I hope everybody can see my slide deck now. Everyone can see it okay? Okay, well, I'm gonna go ahead and just get started here. But yes, we'll talk about all those questions, the adverse events. We'll talk about what makes this new technology, the LX YAG laser technology, different and allows us to safely, more efficacious outcomes as well, and also talk about patient selection. But I'm talking to you here from just near Chicago. That's the little red dot up there, and this is my little eye center down there. My other passion, as Shanaz was mentioning, I'm in a band called Funka Desi. He makes Indian funk and reggae. So if you ever go online, go to funkadesi.com. You can listen to some of our music on YouTube and other social media as well. So my other escape. But I want to talk about the first question that people ask me, well, do I feel comfortable performing laser vitreolysis? Because there is a fear of complications. For historically, there's been a fear of, does it really work? And why all of a sudden now are we promoting this new procedure when it's been tried before? This is not a new concept. So what has changed? And in general, is it even worth addressing floaters? And these are all the questions that I asked myself, because I luckily got started. It was more serendipitous how I got started with floater treatment. I went to the Academy of Ophthalmology in the United States back in 2012, and I needed a new YAG laser anyways. And so I bought this laser, not really thinking about vitreolysis, and it was the first incarnation of their coaxial illumination tower, which we'll talk about. And I started doing a couple cases just randomly. But then what I started seeing in the results and the efficacy and safety, I branched out, did more and more cases. And that was what I realized quickly, how much of an impact floaters can have. But I start out by this slide by saying, when we talk about technology and the indications for a procedure, as technology changes, so does the efficacy and safety. We can't compare vitrectomy from 10, 20, 30 years ago or cataract surgery in terms of its efficacy and safety, because technology has changed. And with technology is changing, so does our indications and our comfort level of performing procedures. Nowadays, we don't wait till a cataract is 20 200 before we do surgery anymore, because our safety is different. And the earlier we treat, the quicker and safer it is. So now, just like a cataract, I'm not waiting and waiting and waiting to take patients out, because we see the benefits of taking care of a cataract early on. Well, it's no different as we do see with floater treatment. Even though floaters are normal, quote unquote, normal part of the daily functioning and daily life rather, it is an impact, and it can negatively impact patients' quality of life. So just because they're normal, I tell patients, yes, cataracts also are a very normal part of the aging process, but we don't watch them forever because they can impact quality of life. And there's actually an interesting study that was done a few years ago. It was published in Journal of Ophthalmology in 2011 that asked patients, what are you willing to risk to reduce the floaters? And how did that compare with the risk tolerance for other type of diseases, whether glaucoma, HIV, cancers? And it found that patients had more risk tolerance than many other diseases, such as angina, asymptomatic HIV, cancers, and glaucoma. And about 7 in 10 people will have a significant floater sometime in their life. Out of those, 30% of those patients will be chronic symptoms. So there's a number of people around the world who are suffering that are literally ignored. And I think we got so used to telling patients, don't worry about it, it's normal, because we didn't have a great option to treat. Vitrectomy is always an option. And I always start out by saying this is not a replacement for vitrectomy. We're not competing with vitrectomy. Vitrectomy is a fantastic procedure, but for a lot of our patients with a Weiss ring or with solitary masses and floaters in the vitreous, let's say are phakic and younger, a lot of our colleagues who do vitrectomy surgery won't want to do a surgery on those patients because of the risks, as you see. Although the risks have gotten much better, we still see a risk of cataract formation, detachments, and other risks. So therefore, a lot of our patients who end up getting vitreolysis are not great candidates for vitrectomy as well. So they're kind of a different type of patient pool, which is why they're both, I think, synergistic with each other. As a glaucoma specialist, I can tell you, I do a lot of SLT and a lot of MIGS, the microinvasive glaucoma surgery, but yet I still do trabeculectomy, but not for everybody. I try the lasers first because of the safety profile, which we'll get to with this laser. But why have people not been big fans of laser vitreolysis? What were the limitations? Well, one of the reasons why it wasn't a very efficacious surgery many years ago was we can't visualize. The standard YAG lasers are not formed or designed to visualize behind the posterior capsule, the middle of the vitreous, etc. Plus, a lot of the surgeries that were done, procedures that were done, and the data that was also published were using energy levels of 1 or 2 millijoules, which is what we utilize for a capsulotomy. As you'll see, as we'll talk about, we're utilizing millijoules of 4, 5, 6, 7 millijoules for these sessions per shot, and we'll explain safety. Also, the number of shots. People were doing 30, 40, 50 shots like a YAG capsulotomy. In these procedures, we're using 3, 4, 500 shots as well. And the energy delivery was not as optimized as we see in these new lasers. So we're going to talk about what we need from equipment standpoint of view. The specialized lasers we'll talk about, with the LX Ultra Q and the Tango Reflex. There's different lenses. We've helped develop a lens that is designed to look through the entire vitreous, and there's also typical topical drops that we utilize. So not a lot of new technology. The most important one is the actual laser itself. So talking about the laser, what makes the laser different? Well, first of all, we're going to talk about the illumination. Probably 90% of what makes this new technology unique and different than standard YAG lasers is the ability for us to see the entire vitreous cavity and see all the way to the retina. So coaxial illumination. Many of our floaters, especially let's say Weiss rings, are in the middle or posterior vitreous. With the standard YAG laser, you do not have the ability, because of its illumination tower, to see beyond the capsule. So we're not identifying many of the symptomatic floaters. But number two, from a safety perspective, where's the retina? And how do we also know where the lens is? Can we titrate the illumination? And that's what we'll talk about. We'll also talk about the energy delivery. What have they done with these lasers to decrease the dispersion, the shock wave of the energy, and how they change the cooling cavity to keep it a consistent laser delivery over a number of shots as well. These are all the technology advances that have allowed us to be more safe. Because if you look at a standard YAG laser, what we use standard YAG lasers for is capsulotomies and PIs. Well, all we need to know about is the capsule. We don't care what happens behind the lens, which is why the designs of those YAG lasers were more for the anterior segment. Well, what they've done here with the LX Ultra Q and the Tango Reflex is they've changed the illumination tower. So a standard YAG laser, as you see here, has an illumination tower in that red arrow coming from a non-coaxial position. So the laser and the oculars are coming from one axis, and the illumination tower is coming from below. That allows us, they converge and allows us to see the posterior capsule beautifully, but nothing behind. Now, on the right, if you have a floater that's in the posterior vitreous, well, can you see that floater? You can't, because they crisscross. The illumination is not in the same axis as your oculars. And that's the reason why we have a hard time visualizing those floaters. So what did LX do? Well, they created something called a flip mirror system, allowing for coaxial illumination, meaning the illumination tower is going this way. When you fire the laser, the mirror goes out of the way, and it allows us to fire the laser. So we have the continuous coaxial illumination that allows us to visualize the entire vitreous cavity all the way to the posterior chamber and to the retina. So it's called true coaxial illumination. And it also allows us to what we call titrate the illumination. I'll show you some videos that allows us, as you move the slit lamp oblique, you can change how much of that posterior illumination to allow for better contrast. And that's an important concept, as we'll talk about, in terms of safety, but also identifying the floaters and knowing where you are in the vitreous for safety purposes. And so there are other laser companies that have come out with Vitreolysis type of lasers that have something called split mirror system that has two different mirrors. That's a little different. It actually takes two mirrors and converges the light. But when you move the slit lamp oblique, you lose that coaxial illumination. So the LX laser is the only one that has that true coaxial illumination. And so why this is important, and I'm spending a lot of time on visualization because this is such an important part of this safety and the efficacy of the procedure. When you're coaxial, meaning the slit lamp is in the middle, you can see all the way to the retina. You can see a nice red glow. And so what a clinical pearl we tell new surgeons is if you see the floater in focus, but the retina is out of focus, where you do not see the vessels, you know you're far enough away from the retina to fire and not hit the retina. If you see the floater in focus at the same time as the retina, then you want to be careful. That's only allowing us through visualization, and that's the coaxial illumination. So here's a slit lamp in the middle position, and this is coaxial illumination fully. Now, you can move the slit lamp oblique, and the oblique position allows us to see more anterior floaters. And we can also see where the posterior capsule is. So if you have a phakic patient with the floater behind the lens, you want to move the slit lamp oblique. This laser allows us to fire the laser in any position of the slit lamp. So we can titrate the illumination. Here's an example of a slit lamp in the oblique position. So these are important concepts, but no other laser allows us to fire the coaxial position and the oblique position to allow us to titrate the illumination. So when we're coaxial, we call it on axis. When we're oblique, it's called off-axis illumination. And again, what that does, it changes the illumination. When we're coaxial, we have a red glow. When we move it oblique, we lose that red glow to see anterior floaters. And you're going to notice on these videos, we're doing both to allow us to visualize. Dr. Biswas, are you using the laser both in the coaxial and oblique position sometimes?
Yes, depending on the position or the depth of the floater, yes, for the same reason.
Yeah, so very, very important concept here. So here's an example of a floater that I'm just going to show you real quick here. And the idea behind this video, I'm not sure how well it's showing up there through the internet, but the most important part is being able to identify the floater, first of all. And so what I'm going to show you here is just a video of me trying to find the floater. Number two, giving myself spatial context. Where's the floater in relation to the retina? And so now I'm going ahead as a phakic patient. I was teaching someone here. And what I'm going to show you now is there's the floater. Now what I'm going to do is I'm going to go back to the retina. So there's the floater. You see that there, I paused it. A beautiful view of the floater with a red glow behind. This is coaxial illumination. No other laser will allow you to get this kind of a view. Now I can see, okay, where's the floater? Let me go back to the retina. So there's the retina. I can go posteriorly and I can see clearly those retinal blood vessels. Now I can go back to the floater to confirm that the floater is in focus and the retina is out of focus. This is why we feel comfortable from a safety perspective. We know exactly where we are. In any procedure in ophthalmology, we need to make sure we have good visualization. And this is what allows us to do that. So now I know that I'm far enough away from the retina, and we'll get to energy delivery and the shock wave in a few minutes. But now that I feel safe, that I know where I am, I can fire. Now what you're gonna notice when I fire, there's gas bubbles. This is plasma creation. In other words, we are vaporizing. One of the most, I think, common misunderstandings and misperceptions is that we're just breaking things up. Yes, we are fractionating, we're breaking, but we're also vaporizing. So we do not stop at 20, 30 shots like a YAG capsulotomy. We keep going until visually we do not see any more of those small opacities remaining. So we break and vaporize, break and vaporize, because plasma is the fourth state of matter, solid to gaseous state. So you're creating small areas, microns of vaporization, which is why we have to do 200 or 300 shots oftentimes, if not more, to vaporize. But you see here, we're breaking it up and vaporizing. And number two, because of the energy delivery, we're not seeing this floater shooting everywhere. There's not a lot of disruption of the vitreous because of the energy delivery being so consistent as well as efficient. We're not seeing the scattering of the floater as well. So this is just an example of what it looks like to us, but the visualization is crucial. Here's another small example of a video where I see a small Weiss ring. These are small floaters, people who would not qualify for vitrectomy, where the vitreolysis is a great option. Now, if I move the slit lamp oblique, I can't see the retina. I have to use coaxial illumination. I can see there's a retina all the way back. There's a pseudophakic lens, and now there's my floater. So what I have just done in the last 10 seconds here is given myself spatial awareness, spatial context. Now I know as a surgeon where I am at all times. Now I can feel comfortable. The retina is out of focus. I'm in the middle of the vitreous and I can fire the laser. As we'll get to, even at 10 millijoules, the shock wave is only about 300 microns. So we're not going to cause a large disruption of vitreous. This is why the illumination is so important. This is one more example here, then we'll move forward. Another Weiss ring. Again, these are beautiful views that we see because of the coaxial illumination. Again, no matter what lens you use, if you do not have coaxial illumination, you will not have the ability to actually see these kind of floaters and this type of a view. Again, the retina is out of focus and the floater is in focus. I know I'm safe. And this is exactly what we need to utilize. Other standard YAG lasers will not give you this. This is why now we feel safe to perform this procedure and we can identify floaters that we could not identify in the past. Very important. Well, the other question though, so we talked about coaxial illumination, but the fear a lot of my colleagues have is, well, if you have a phakic patient, what do you do? Now, Dr. Biswas, do you do floater treatments on phakic patients as well?
Yes, I do.
Okay. And do you feel safe doing that?
Yeah, I haven't had a issue as yet. No difficulties that I can recall.
Okay. And the reason I brought that up is because here's an example of a phakic patient with a large cloud behind the lens. Now, the patient went for a vitrectomy consult. The vitreous retinal surgeon said, I'm not going to do the procedure on you because it's too close to the lens and I'm going to cause a cataract very quickly. So he came to me. So I was afraid of the same thing. And as I'm firing here, I can't see the posterior capsule. Where is the posterior capsule? I don't know. So here's where the beautiful thing about the laser, I can actually now turn my slit lamp oblique. By moving the slit lamp oblique, look what I've done. I've moved my coaxial illumination and I've titrated it away. So now I have no red reflex because the floater is right behind the lens. But now I know where the floater is in relation to the posterior capsule. So as I start firing here, you're going to see all of a sudden I'm firing. Now I'm going to stop and say, where's the posterior capsule? Okay, so there's a posterior capsule. Now I can move posteriorly and see there is the floater. So the space between the lens and that where I fired is like the anterior chamber depth. That's how we can understand how far we are from the posterior capsule. So being able to titrate the illumination, going oblique like I did now, or coaxial if it's further back, allows us to know where we are in the vitreous. Again, spatial awareness. And this is what makes this laser so unique. And even these cloud-like large amorphous clouds, we can fire and we can do a great job of getting rid of these. Now, some of these larger amorphous clouds need multiple sessions. We can't get rid of all these floaters sometimes in one session, but we can debulk it and break it up enough where patients a lot of times will have 50, 60% improvement, 70% after one session, and we can do a second or third one if we need to as well. But that's the idea of moving the slit lamp oblique. And the last concept I'm going to bring up is illumination titration. No other laser will give you the ability to titrate the illumination. So on my right, you'll see on your left screen, that's me with a laser. On the right, you'll see my view. Now, there's a small Weiss ring in the middle of the vitreous. I'm coaxial. What I want to show you is as I move, there's a retina, there's the floater. I'm seeing a beautiful view of the floater. But what I can do is I can titrate away. And as I move the slit lamp oblique, I can move some of the illumination away to give myself better contrast. If I move the slit lamp too far oblique, I cannot see the retina. Now what I can do is as I bring that slit lamp towards the middle, look what happens to the illumination. As I bring it to the middle, I give myself more illumination, but now it's too much glare. So I can move it 10 degrees oblique. And now what I've done, I've given myself better contrast with the floater, but I still have enough coaxial illumination to see the retina. This is called titratable illumination. This is what we can do to maximize our view, our contrast with the floater, but still have spatial awareness. Again, no other laser allows us to do that. And you see here, I'm breaking up, but also vaporizing this floater. It was all gone now as well. So that's important. Last slide here.
Clicking sounds here. Just make sure there's a lens.
So here's another example of a titratable illumination, large mass in the middle of vitreous. If I'm oblique, I can't see it. If I'm coaxial, too much glare. So what I can do is I can move the slit lamp about 10 or 15 degrees oblique. And by doing that, I remove some of the anterior glare, but now I can move posteriorly. I still have enough coaxial to know where the retina is. So again, this is a phakic patient. So I want to make sure that I'm far enough away from the phakic lens again. So what I'm trying to get to is a visualization is such an important part of the safety and efficacy, which is what makes this technology different as well. Let me just fast forward for the sake of time here. And then I'm going to go ahead and show you multifocal lenses. One of the most big benefits I've seen are patients who have premium lenses and are miserable after. People have a hard time with reading because of these floaters. And so even through a multifocal lens, you can get great efficacy with this laser. And I tell you, these are the patients who I've gotten referral from where they're having a difficult time reading J3, J5 because of the floaters. And we've done a study we published a couple of years ago at ASCRS showing us that we've improved reading by 2 lines with these amorphous clouds that are in the middle of vitreous just by taking care of the floater. So from a quality of vision, especially these multifocal lenses, these amorphous clouds can make a big difference. So even through multifocal lenses, we can see a big difference as well. Lastly, here before I move on to from the illumination, is even for YAG capsulotomies.
Sounds here. It's going to clear up the cloudiness here. Get rid of those small pieces because that's the floaters that people complain about.
So here's an example of a floater treatment here, where a capsulotomy. And what I've done is I can go coaxially to see where those floaters are or where the capsule are. So if I do a laser here, getting rid of the capsule, but what happens is you have all these small pieces that can remain. And so by using coaxial illumination, even for YAG capsulotomy, I can see small remnants of the posterior capsule that I couldn't see with my standard positioning. This way, we can decrease the amount of complaints that people have after YAG capsulotomy with floaters. So this is why I think this laser is wonderful for YAG caps and how I use the coaxial illumination even during my YAG capsulotomies as well, decreasing the risk of patients complaining of small floaters after YAG capsulotomy. So very efficient. All right. Any thoughts so far? I want to move forward a little bit there, but any thoughts so far, Dr. Biswas, on what I just mentioned earlier?
Well, I must inform you that there's a question by Dr. Regis Tan about an apprehension about the question about the number of shots that one can deliver for this laser. His question is it 250 or more? What is safe?
Sure. Well, I can tell you that the data we published, we've gone up to 1,000 shots at 6 millijoules. So we have not seen, we have done some studies using something called the ADAPT-DX, which is looking at rod functionality and retina function. And we've done over 2-year data following different ranges of number of shots and energy levels. And we have found no degradation of retinal function. So I don't have a number to give you that's perfect. Because, and I'll tell you the adverse events, I have seen some patients develop IOP spikes, pressure spikes. We think it's either because of the gas bubbles, but also the particles that can float around into the anterior chamber and block the TM. So what I'll do is I'll limit the number of shots, not because of retina function, but because of IOP spikes. So around 400 or 500 shots is where I kind of stop now, just to be safe because of IOP spikes rather than retina functionality. So far we're not seeing that upper limit. So, but me personally, I stop around 500 or so shots on average. Dr. Biswas, how about you? What do you stop at usually?
Well, yeah, something similar. I don't go up to 400 to 500 shots. I limit myself to about 2000 millijoules total energy. Do you go by the number of shots or by the total energy delivered?
I go by the number of shots, and here's why. Because energy delivery, if you look at the energy, we'll talk about right now, the energy is dispersed, the heat is dispersed within 3 to 4 nanoseconds. And it's the heat is dissipated before the next shot is fired. Number two, it's such an efficient delivery of energy that, and because of our studies looking at retina functionality, looking at VEP, ERG testing as well, we have not seen a degradation of retina functionality. What I have seen though is when you have a number of shots, not only do we see gas bubbles, but there's more particles disrupted that we can get IOP spikes. So for me, my fear has not been retina function for the number of shots, it's more IOP spikes. So that's, for me, I used to go to 2,000 shots, 1,500 shots at 6 millijoules, so many, many thousands of millijoules. And I did not see retina dysfunction, but what I did see was IOP spikes. So that's the reason why I limit the number of shots. So the point is we don't have an upper limit yet. I would more limit it based upon the comfort level of IOP. But I'm gonna get to pressure. It's a very good question. So thank you, and please feel free to ask more questions. This is really important, so thank you for that question. But to talk about energy, because that's a very important question. How much energy can we deliver? And is it safe? Are we gonna cause disruption to the vitreous or retina function? Well, if you look at the data, it's a 3 nanosecond pulse. But what they've done is they've truncated the energy beam, made it a sharper rise and fall. What that does is decreases the amount of dispersion of energy in the eye. And so there's a very important concept that a lot of us have not learned in residencies. And this is something I had to learn after learning about this procedure. When you fire a YAG laser, the laser energy that's delivered into the vitreous forms an acoustic wave of energy around the plasma. And then you have a shock wave that comes back towards you. This is called the plasma. That plasma comes towards a source. So the entire distance from left to the right, to that right side of that acoustic wave is called the convergence zone. Think of it like the shock wave. And there's a shield that forms when your plasma forms that prevents further posterior propagation. So in other words, when you look at data, in vitro data on shock waves, this is a really important study that was done. There's a non-linear relationship between how much energy is delivered in the laser versus how much a shock wave is formed. So as you increase energy in the laser, the dispersion of energy in the eye is non-linear. So at 1 millijoule, the shock wave, this is at a liquid interface, is about 110 microns. If you go all the way to 10 millijoules, right? That's higher than I go. I usually go about 5 or 6 millijoules. But at 10 millijoules, the shock wave only goes up to 210 microns, less than a 50% increase, but yet a 10 times increase in power. So that's why the fear a lot of people have of going to 4, 5, 6 millijoules is, well, I'm going to cause such a large disruption in the vitreous. But we do not see that clinically, and we do not see that also in our in vitro studies because of this energy delivery. Here's an example though, real time, of a study that I did that we presented at AAO a few years back that looked at real-time visualization of the vitreous cavity as we're firing the laser. So we held a iCube here temporarily while we were firing the laser to see what was happening. And I want to show you is, bottom line is, you're going to see in a second that there's the line you see, that's just the sound waves. That's an artifact. But what you see is that floater, that large opacity, the vitreous around it's not moving. There's very little movement of surrounding vitreous with this procedure. In other words, the vitreous cavity is very quiet around where we fire the plasma, which I think is really important concept. Again, you see that nice opacity, the surrounding vitreous is not moving very much at all. And that's because the posterior face is not disrupted. We looked at the posterior hyaloid face, we found no disruption there. Let me see if I can fast forward here. There we go. Okay, so that was our evidence that the energy delivery is so consistent, so confined, that we're not seeing a large disruption of vitreous as well. Lastly, energy is also stable. We did a study that also presented at ASCRS a couple of years ago, looking at this cooling cavity of these lasers that we have here compared to a standard YAG laser. And we find is even after 200 or 300 shots, the energy delivery is more stable because they're active cooling cavity. The traditional YAG laser without an active cooling cavity, you see the energy delivery rising and the heat rising over time and that right side there. And so in other words, what's also important compared to a standard YAG laser is our ability to keep consistent levels of energy and heat throughout the entire process versus it resetting, going beep, having to reset the laser again, which happened in other lasers when I've tried as well. Just to show you the efficiency of energy. This is something I do not want anybody out there to do at home, but I want to show you something. This is a patient who had a floater right behind the phakic lens, came from London and wanted me to do a procedure. I said, no, but she said, please, doctor, please. So I went ahead, and this is at about 1 millimeter from the posterior capsule. I had about a 100 micron posterior offset on the laser. But what I want to show you is even at 6 millijoules or 5.5 millijoules, how efficient the laser is, and we did not break the capsule. And I want to show you something right here. So there's a floater, there's a posterior capsule, and you can see now as I fire that I'm not breaking the capsule. I'm partially coaxial. I have a slight oblique so I can see the capsule there. But that's how efficient the energy is, even at 5.5 or 6 millijoules. And so the reason I brought this up is because of that reason of efficiency. There's another video looking at the posterior hyaloid face. Yes, you have a question?
No, I just said, wow, that was very close to the capsule.
Yeah, it's amazing how you can get close. I'm not saying you should do that, but here's an example of the posterior hyaloid face. You can see back here, the posterior hyaloid face is not moving as we're firing at this floater, which is about 5 or 6 millimeters anterior to the limbus, to the retina. So the posterior hyaloid face does not move. So when people ask me, Paul, are you causing traction? Are you causing detachments? We're not seeing the pulling that you see with the vitrector, which is really important. And that's the reason why that we don't see that. But well, let me go ahead and just, I know we're kind of getting short on time. I'm gonna give me another 5 more minutes because I want Dr. Biswas to have time. But I want to just leave you with a couple data points, because I know a lot of people wonder, well, great, Paul, these are wonderful videos, but let's talk about data and safety. Now, historical data is not very good. And if you look at why, a lot of the reasons why is the energy levels were 1 millijoules, or they were doing 20, 30 shots. They were only doing a specific type of floater, only 1 session. And so when you look at historical data, they're using different technologies with different techniques and different protocols. And that's why it's so hard to compare. But we'll talk about some newer data. Dr. Chirag Shah published data recently in JAM of 2017, and his follow-up was just recently presented as well, showing us that compared to a placebo group, meaning a group that had a sham treatment, we found that there was a significant difference in patients who reported improvement. So there was not kind of placebo effect like people think. Number 2 is the safety was very high. Over a year in this study, there was no detachment seen in the active group, in the treatment group. In the group that was a placebo had 1 inadvertent detachment. So in other words, safety was maintained at this study. We published data and presented data at AAO, this is at ASCRS in 2016, showing that out of 362 patients, prospective study, 90+% of patients said, yes, it made a difference. We saw an average of about 70% improvement after 1 session. Some of these patients needed multiple sessions, about 90% improvement after multiple sessions. So we tell them, not every floater I can get rid of, but I can make a significant difference. A Weiss ring is a wonderful, wonderful, wonderful way to start because it absorbs the energy very well. And usually 1 session can get rid of pretty much all of the floater, and usually less number of shots for a Weiss ring. For those amorphous clouds, you can sometimes need 300, 400, 500, or 600 shots, depending on how dense and how diffuse they are as well. But in terms of safety, we found I did hit the retina, and I'll show you a video on that. And the good news about hitting the retina, if you hit the retina periphery, it'll go away and you should not see an adverse event long-term. But the retina you hit is not because the laser's unsafe, it's because you as a surgeon have to know how far back you're able to fire. And that took me a few sessions to figure out. Dr. Biswas, have you hit the retina yet in any of your cases?
Yes, in 2 cases in my earlier days, but not because nothing to do with the laser. It was my error of not adjusting the eyepiece for the focusing of the Myers.
Exactly. That's a good point. It's not that the laser is unsafe or the procedure is unsafe. It's we as surgeons who are unsafe. And I hit the lens in 2 patients until there is a learning curve. And the learning curve is to know how to titrate the illumination, how far back from the lens can you be? And that takes time. So I did hit 2 lenses, and I'll show you that. In the study here, we had 3 patients with pressure spikes that needed medications. Now over 6,000 sessions, I've seen more pressure spikes, of course, but still the total adverse event profile is less than 1% in my hands as well. And so the people who get pressure spikes tend to be patients where the floater is right behind the lens, in a YAG cap patient, where we think the floaters can go around the anterior capsule and go into the AC and block the TM. That was an older slide. I've done about 6,000 studies now. But I just want to show you my total adverse events. We did a study here we presented last couple of years ago. Over 1,100 patients, we found that we had no exacerbation of inflammation, no exacerbation of macular edema in diabetic patients. We had, again, pressure spikes, total of 7 out of the 1,200 patients. And I'm going to show you the retina that I hit here and the lenses. So these are 2 lenses that I hit. The reason I hit these lenses was because I did not titrate the illumination. I did not turn the slit lamp oblique. So these happened in my first 20 cases until I realized how to maximize the view. Now, the one on the right ended up needing cataract surgery. She did very well, actually, but she was symptomatic because they see the large opacities. The one on the left side here is actually now 6-7 years later, is still has not changed. Patient's asymptomatic, so we're leaving that alone. But you can hit the lens, so you have to be careful. And that's why we tell you to pick pseudophakic patients first, because it is safer from that perspective.
Okay.
Now, this is a video of me hitting the lens, or hitting the retina. Now, what I want to show you is why. It was not that the laser was safe. You see a large kind of a linear opacity right in the posterior part of the vitreous there. And now the key is, see how in focus those retina vessels are. If you see the retina vessels that clear, as well as the floater, do not fire. You're too close. And especially early on when you're trying to figure out how to use the laser, this is way too close. So it's not that the laser was unsafe. Me as a surgeon, I'm firing at a very clear retina, which is my fault. Now this is nasal. You see that little white spot that formed? I'm firing at the retina. So it's not that the laser was unsafe. I chose to fire inadvertently. So now, after about 5 minutes, I was very nervous. I watched a round red spot formed, and that was the largest it got. Now it went away within 3 months. It was gone. Patient had no symptoms because it was away from the fovea. So this is why I don't worry if I hit the retina, but you will not hit it if you know where you are in the vitreous cavity. Now, let me just fast forward here. I'm sorry if I'm taking too much time here. I want to give you enough time, Dr. Biswas, but I just want to share with you guys.
Please
do I have enough time?
Carry on.
Okay, sorry. If you need me to cut short, I will. I don't want to take too much time. But I think it's important to realize that we do have objective data now, and objective data on improvement. Now, Dr. Biswas, have you noticed patients would come to you after doing treatments of floaters and say, I can see better, but on the charts, they were seeing the same. Does that happen to you?
Yes, it does. Yes.
And that would happen to me all the time. And I think for me, I had a hard time objectively identifying why was that. Why were they seeing better when they were still the same visual acuity on the chart? What we found is we use this technology called ray tracing, some company called iTrace or Tracy Technologies, which shines 256 lasers into the eye and looks at where those retina lasers or those lasers fall on the retina, looks at point spread function, the intensity and the size. So it can look at cornea, because it has a topographer, versus internal optics. So it can separate cornea versus internal. And so what we did is a study that we also presented at ASCRS, showing us that we can separate and look at the improvement in internal quality of optics pre and post floater treatment for those patients who had amorphous clouds in the middle of the vitreous. So if you look on the left, that is the left is a representative E, that's a cornea topography. You look at internally in this middle, it gives you a number, dysfunctional lens index. Anything behind the cornea to the retina is the internal optics. And it gives you a scale. Looking at the number scale, below 7 or 6 is considered significant. This is a patient who came in with a large amorphous cloud in the middle of vitreous, the DLI of 3.7. On the bottom right, you'll see here that it separates internal versus corneal aberrations. You see the cornea had low aberrations, but 0.195 internal aberrations were high. Now look what happened after the treatment the next morning. Patient increased the DLI to 10. Patient said, I can see better. And look at the internal quality of optics. The aberrations internally went down from 0.195 to 0.087. The cornea did not change. The refraction pre and post did not change. So in other words, what we're finding is quality of vision can be assessed, and we can see now the benefits of a quality of vision pre and post. This is again, the MTF curves, the modular transfer function, the contrast sensitivity. And we find here on the left, that arrow, you should be at 10 cycles per degree, you should be about 0.6. This patient's low. After the procedure, we improved the MTF, the contrast, significantly, the area under the curve. So in other words, here's another example, pre and post, showing us an improvement in the actual DLI. So now we also have evidence of the retina and the OCT. We published the data at OSLI looking at pre and post vitreolysis, looking at OCT of the fovea and macula. Here's an example of a patient who had a scotoma, came in for a second opinion. It was a large, massive floater there over the fovea, and you can see a shadow cast on the retina on the 5-line raster. And so we did the laser treatment, and look what happened. We got rid of the middle sections of that large floater, and look at the shadow, it's gone. So now we can see objectively too, using OCTs, that the shadow cast on the retina is also gone. So again, a number of different data sets now showing us there's an improvement in quality of vision, but also symptomology. Here's just another OCT pre and post-op a week later showing the shadows gone and the patient's symptoms were gone. So we're now finding that this is not just patients who say they're better, but we're seeing objectively. In our results of that eye trace data that we presented, we did found an improvement in MTF curve and an improvement in higher order aberrations pre and post. And looking at HOA, trefoil demonstrated the biggest improvement in these patients with these large amorphous clouds. Well, I wanted to stop there for now because I know Dr. Biswas has some fantastic slides. So I'm going to stop sharing my screen and have Dr. Biswas take over from here, and I'll come back after Dr. Biswas is done. So thank you for the opportunity.
Thank you, Dr. Paul Singh. Thank you very much. Dr. Biswas, I invite you to give your session, as well as the next poll questions.
Yeah. Is my title slide visible?
Yes, it is.
Okay. See, I'm going to show only a few slides because Dr. Paul Singh has dealt with the topic very elaborately. And I'm just going to show a couple of my cases and the documentations. This was one of my earlier cases. Okay, you want me to conduct the poll first?
Yes, please.
Okay, so there's a poll question now. How many symptomatic patients for vitreous floaters do you see in a month? And we have 30 seconds for answering. Viewers, please click your answer and submit. In a month.
How many do you see a month, Dr. Biswas?
Well, I would be saying that every day I see about 3 to 4. It depends. Now during the lockdown period, the numbers are less.
No doubt about it.
Okay, great. When do we get the results of the first 3 questions in the first poll session? We haven't seen them yet. Anyway, I'm sure we'll catch up later on. So this is one of my initial days lasers of a 61-year male who had floaters in both the eyes, and he was having difficulty in reading, TV watching and all that. And I told him the option of the laser, and he said he wants to take a couple of months time to decide. And where's the next slide? Okay, so this is a fundus photograph with the Heidelberg spectralis of the floaters in the right eye and the left eye. And these are the other devices, documentation, as Dr. Paul Singh already talked about, the OCTs showing the shadowing, the ultrasonography showing the hyperechoic areas, and the visual acuity, quality of vision disturbance by the simulated visual acuity as seen by the eye trace or the ray trace technology. Now, this patient, and those are my initial days, so I was apprehensive about the amount of laser delivery and all that. So I did the right eye in 2 sessions and the left eye in 3 sessions. And in the right eye, as we can see at the end of it, this large floater had disappeared. And in the left eye, this one, as seen by the ultrasonography, the pre-LFR and the post-LFR, patient was symptomatically very happy, and that is the most important thing, and he was able to do his day-to-day activities comfortably. Now, I want to show a second case, which I did today morning. So now I have more experience than in my initial days, and I'm much more bold than in my initial days. So I take up tougher cases. And this was a very thick wise ring of a lady from Calcutta. She's one-eyed. She's one-eyed, and she had difficulty in her day-to-day activities. She reads a lot. And this is the larger wise ring, which is very thick. And this shows the OCT, and you can see the ring in the vitreous cavity in the OCT tracing. And post laser today, I did the laser today, and the wise ring is not there. You can see in the ultrasound also that it is not there. She is very happy immediately. So the important thing is this procedure gives a dramatic instant relief to the patient. Well, there was a question you asked me, how many patients do I see? I read this in literature that on an average, about 7 out of 10 persons will have floaters at some point of time in their lives. I'm not going to go about, so this is a general thing. Until I had this laser system in my hands, what do we tell the patients? I used to tell the patients to ignore the floaters or get used to them, or they might go away on their own, things like that. But now we have an answer. As you said, as Dr. Paul Singh said, vitrectomy is not for everybody. It is a good procedure. It is expensive and it has its own complications, possibility of complications. Thus far, I have done nearly 200 eyes, and I have already mentioned during the discussion that there have been 2 cases in which I have hit the retina. One of the patients had very large vitrectomy. This is the patient, Dr. Paul Singh, who had I had taken to you, and you had taught me or shown me the laser delivery hands-on on this patient. He finally underwent vitrectomy. He had so much of floaters. So somebody asked, there has been a question by Dr. Yashowanta Nayak about patient selection. So I generally select patients who have symptomatic floaters causing vision degrading myodysopia and compromise of quality of life. I do a detailed workup, and I avoid patients with poor pupillary dilatation, patients who have hazy media, and the ones with significant ocular comorbidities such as uveitis or glaucoma, macular edema, and other retinal disorders. I always do a detailed hand-drawn drawing in my medical chart to exactly locate the depth and the position and the size and the shape of the floater. I also document it with a fundus photograph and an OCT macula, ultrasound, eye trace, sometimes with a contrast sensitivity also. Informed consent is also a part and parcel of the workup. Next slide. There was a question from Dr. Dinesh Rungta about post-laser advice. What do I do? I don't give anything special, no drops or anything, or no special instructions. Patient before the laser had the floater, and after the laser immediately does not have the floater. The only thing that I do is I check the intraocular pressure. I usually call the patient at 1 week, 1 month, and 3 months and record the pressure and other examination routinely. What do you do, Dr. Paul Singh, for the post-laser advice?
That's a great question. The good news is we do not see evidence of inflammation, whether that's the anterior chamber or posterior chamber. So I do not routinely give, like I said before, I don't give any kind of anti-inflammatories, whether it's NSAIDs or steroids. But I will say, those of you out there who do YAG capsulotomies and normally do put people on steroids, go ahead, do what you normally would do for a YAG capsulotomy, but we do not see any inducement of inflammation.
Okay, so there was another question from Dr. Madan Mahapatra, whether the floaters disappear totally or not. Well, in most cases, in a large majority of cases, they disappear totally, but it also depends on the size, the density, and the extent of the floater. The important thing is whether it is causing any visual disturbance or to the quality of life or not. In most cases, the patient is free of the symptoms. I just want to touch upon that there is a learning curve. It is a very simple procedure. I think anybody can take it up. It's like any other YAG laser machine. There are lights, you have to focus, and you have to shoot. As Dr. Singh pointed out, spatial awareness is very important. And when you had taught me hands-on, thereafter my own awareness of the spatial awareness has improved a lot, and my confidence has improved. Thank you so much. Another question was there from Dr. Ashish Holani as to which lens is used, whether it's one of the retinal laser lens or 70-80 lens. No, the lens that is used is devised by Dr. Paul Singh himself, and it's called the Singh mid-vitreous lens. Would you like to say anything about this lens, Dr. Paul?
Well, I have no financial interest, as everyone knows, but it's a wonderful lens. It allows us, we designed it in such a way that it gives you a beautiful view all the way from the lens to the retina. And so, yeah, that has become our main lens. I will say, because we don't have yet a prism in the lens, an off-axis lens. So for those in the way in the periphery, sometimes I will go to the Ocular Instruments lens, which has a 25mm off-axis lens, has a prism, gives you about 5mm of prismatic effect. So I'll use that maybe in about 2 or 3% of my patients, but for most 90% of my patients, I'll use the mid-vitreous lens.
Yes, I agree with you. For localization of peripheral floaters, it's difficult. Uh, yes, but I'm much more comfortable doing that nowadays than in my initial days. In the initial days, I also had this fear of administering a lot of power or energy or a lot of number of shots. And somebody, one doctor, Dr. Dhawal Rajiwala, has asked a question about how many shots. I think that has already been answered. You mentioned that in one session, you limit yourself to about 400 to 600 shots. He has asked another question that how much energy per shot and how many shots does one give? So both are the same. So energy per shot is about 5 to 6 millijoules. That is what I use. I start off at 5 millijoules. That is what Dr. Paul Singh you had taught me to do earlier. Before meeting you, I was using smaller or lower energy levels of 3 to 4 millijoules, and I wasn't happy with the results. Ever since I used 5 millijoules to begin with, the results are fantastic.
Yeah, I agree. I think that the only time I'll turn it down is if I'm very, very close to the posterior capsule. Let's say, it's a pseudophakic or phakic patient. There's a string right behind the lens. I'll go down. I'll start a little bit on 4 or so, 3.5 to 4. But my sweet spot on average is about 5 to 5.5.
Okay. In today's case, the one I showed, the lady with the very thick wise ring, I had to go up to 7 millijoules to get the desired result. In summary and in conclusion, it's a fantastic procedure. The best results are obtained with solitary, well-defined, not too thin and not too dense wise rings and with vitreous condensations. It's a very fast procedure, hardly takes now more than a couple of minutes or 3 minutes to complete the entire procedure. It's simple to learn, and it's very, very safe. With proper patient selection and adequate counseling, it's a very gratifying procedure, not only for the surgeon, but also for the patient instantly. Many of my patients describe to me or give me a running commentary during the procedure about how they can see the particles break up and drop down like fireworks. And they love seeing that. That's a great description from some of the patients. Thank you. Thank you for your patient hearing, and wish you all good health. Dr. Paul Singh, can you summarize, and if there's anything else you would like to talk upon as to how does a person start doing it? What are the advice you'll give for beginners?
Yeah, we had some great questions there. Do me a favor, I'm going to go ahead and just share my screen now.
Yes,
you can just, if you were there, let's take a look here. Okay. I think if you press stop on the top there, should be a stop sharing the screen. And there we go. Great. I'm just going to share mine. But yes, those are great questions that people have asked about in terms of how do we, where do we start? So I'm just going to fast forward through Dr. Biswas's presentation here. And so what I would do is, first of all, pick the right patient. And how do we know in the exam room lane, what do we do? Well, I look at number one is, can I see it? Do not treat a floater unless you can see the floater and you can correlate that with the patient's symptoms. There's a disconnect. Patients may have 4, 5, 6 different floaters and they may only bothered by one. So historically, when I ask symptoms, have them write it down for you. I'll have them draw it for me on an AMSL grid, say, okay, where does it look like? Where does it come from? Does it come from top to bottom? That way you can isolate which of the floaters is the one that's clinically significant. But then also look at location. If it's too close to the lens, too close to the retina, and at first don't treat it. Say no. I'd rather say no than cause a problem. But if you have it in the middle of vitreous, then I look at the density, the number, and size. If it's large, amorphous cloud, those strings you see on the left there, that a large wispy string there, those rope-like defects, it can take a number of sessions. So I tell patients ahead of time, a small white ring, 1 session, most likely, I can get rid of it. It may break up into smaller pieces, but a majority of time when they come back, those small pieces are insignificant. And with our studies show 80% of patients after a white ring, if they have any residual small floaters, they go away within 6 months. So that's not a problem. But if you have a larger amorphous cloud, you have to tell them ahead of time. This may require multiple sessions as well. If it, like I said, these are how I examine patients. If they're too close to the lens, I would say don't do it. So if you look here on the left, that patient's floater is right by that posterior capsule, too close. The one in the middle of the screen here, I will do that, but at first I would recommend holding off. Those floaters are so amorphous and they're so close to the lens. On the right though, what you see on the right there, these floaters here, I think are on the right side, are far enough away, that's at least about 6-7 millimeters away, I feel very comfortable treating those kind of floaters. So again, being able to assess how far they are from your lens is very important. Here's an example of something called a floater finder, which is another tool that you can use that allows them in the office, even when they're dilated, they look through a small pinhole and it has a grid, like an AMSA grid on the other side, and they can actually draw their floaters for you and draw where they are and where they're located. So it's kind of helpful in some of our patients. But the key is picking the right patient. Pseudophakic at first is wonderful because you don't have to worry about the lens. Use that pseudophakic patient, even start practicing after YAG capsulotomy. Do a YAG cap and just kind of fire just behind the vitreous a little bit there for those floaters you see right there. Just kind of get used to seeing behind the lens. Weiss rings are wonderful because they absorb the energy very well, very high patient satisfaction. It's also easy to correlate the symptom with what you see. If it's in the middle of vitreous, it's wonderful. If it's too close to the retina or lens, for the first few, I would avoid those. I don't try to do anyone who had a new PVD. I would like to have someone come back in 4 to 6 months, recheck their retina. I've had about 3 or 4 patients who came in for a new PVD. I said, let's wait. I had them come back and I saw a small tear that I missed initially. So I always say, wait and make sure that the PVD is rechecked before and the retina is checked before you do it again. Simple things. If it's hard to see the floater, don't do it. If they're going to be hard to keep still in the laser, have a tight fissure, a tight orbit, those are all things that you want to be aware of for the first few patients as well. But it's always about visualization. Make sure you practice. So what I do, and I tell any new doctor, take the Singh vitreous lens, and in your consult room, put that lens on the cornea and practice the visualization, because that'll give you a better sense of what it's going to be like when you go back to the laser room. And because there is a little bit of a difference between your 90 diopter lens view and the view you get with the Singh mid-vitreous lens or any of these lenses that we use. So that's a way to practice as well. And again, you're gonna have to titrate, as Dr. Biswas said. There is a learning curve. Being able to feel comfortable going oblique, coaxial, etc. Those are all little nuances, learning when to fire, how to maximize. If the floater is this long, I'll fire on top because gas bubbles form. So what'll happen is you fire, it'll push the floater up. So what I've learned is to fire on top of the floater first to prevent it from going up further. And so these are all the nuances that you'll learn as you get more comfortable doing the procedure as well, like any other procedure as well. Again, things like asteroid hyalinosis, there's some patients who don't have a good option for vitreolysis. Vitrectomy might be a better option. So not every floater is treated. So you want to be honest about it. People who have solitary clumps, clouds, very good candidates. People like asteroid hyalinosis, large, massive floaters everywhere. A vitrectomy might be a better option because you'll be doing thousands and thousands of shots over multiple sessions, maybe very difficult as well. I know there's a couple of questions before I finish here that I wanted to make sure. Can you use any other posterior lens aside from the Singh mid-vitreous lens? You can. I've used different lenses. Ocular Instruments makes vitreous lenses. You can use a Mainster or Rodenstock. It's just the view is not quite as the same. I think the quality of the optics and what we've done with the convergence zone or the convergence of the optics allows you to see really, really clearly in the middle of the vitreous. But you can use any lens if you need to as well. Do you need to have a PVD first? I do like to pick patients who have a Weiss ring or a PVD first. I think you have less chance of inducing a PVD with the laser and causing any retina traction. But I have done a number of patients who are younger, who do have solitary floaters that I have done who haven't had a PVD. And like I said, knock on wood, so far we have not seen an increased risk of detachments in that arm of patients. Diabetes, there's a question about diabetes. Yes, I have done it in patients with diabetes, but not active DME. So if they have active DME, I tend to make sure that we use the intravitreal injections if we need to, or focal laser. I try that first if we can, because I feel like there's the less chance of causing a problem. Now, I have done people with VMT, vitreomacular traction, people with ERMs, that I have done, and we have not seen an exacerbation of any ERM or CME inducement from the laser as well. Another question was, do you charge per session? I'll tell you in the US, but Dr. Biswas, do you charge or do you go through any kind of insurance? How does that work in India?
That would be a personal thing because it will depend on the business setup or the method system under which the center or the clinic is running. It would be an well, what I do not charge at all the settings. It depends. If I feel that it's a large enough floater which requires multiple sessions and the patient is mentally acceptable to that, then he's charged. Otherwise, I don't.
Okay. There's a great point. I know there's one question, can a YAG capsulotomy laser be used for vitreolysis? Well, this laser does do YAG caps beautifully, as I showed earlier, but a standard YAG laser that does just only YAG caps, unfortunately doesn't have that coaxial illumination. So that visualization we talked about, being able to see all the way to the vitreous, a standard YAG laser, whether it's a Zeiss laser or even LX's standard YAG lasers, that the non-coaxial lasers, the non-reflex lasers, they can't do it as well because you cannot see those white strings. They can't see all the way to the retina, unfortunately, as well. So that's one of the biggest issues we face with standard YAG lasers is our ability to see behind the capsule very well. There's a question here about the Karakov lens. Karakov has a great book. He was one of the fathers of vitreolysis many years ago, before I started doing it. And he has a wonderful book if you want to get that as well. His lenses that Ocular Instruments makes are very good. They don't get you quite as far to the posterior chamber as well. They don't get as close to the retina, especially for those longer myopic eyes. So that's where the mid-vitreous lens, I think, helped a little bit more. But it's a good lens to use, and it's nice and small and ergonomic. So it's a lens you could use as well if you needed to, but I find the mid-vitreous lens is a little bit better. Another question here is, what is the clinical difference of 1 pulse per shot and 3 pulses per shot, given the total energy are the same? Well, the total energy is higher per shot because you have 3, but yes, you're gonna have the total energy you want. My advice is, if you have a solitary Weiss ring, I use 1 pulse per shot. I go very fast. You can fire 3 shots per second with this laser. So in other words, there's no way you can fire fast enough. So I go very quickly with 1 burst. But if I see a large amorphous clouds in the middle of the vitreous, I'll tend to use 2 shots, 2 pulses per shot. The reason I don't go to 3 is we talked about that cooling cavity. Well, even though this is the most amazing cooling cavity, at 3 pulses per shot, if you fire quickly, click, 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 it'll overheat no matter how good it is. And so it'll have to reset. So I find at 2 pulses per shot, I use, if it's a larger amorphous cloud, thicker, denser, to be more efficient. Otherwise, I'll go to 1 pulse. Dr. Biswas, how about you? What do you utilize?
Always use one shot, 1 pulse per shot. That gives me a sense of better control in my hands.
Yeah, I agree. It's very much more control for me too as well. I just wanted to leave you here with a little bit of flow. I think what you'll learn in your practice is you'll have a flow, whether you do it at the beginning of the day, end of the day, certain block scheduling. We do tell the patients they'll be dark for about 5 or 10 minutes because of all the flashes of light. We tell them it's gonna be blurry because of the vitreous, of the gel rather, on the cornea. And they may see some gas bubbles. They may see new floaters for a day or so because of the gas. But they can go back to any activity, as Dr. Biswas mentioned. The most amazing thing about these patients is they can go back to any activity right away, and they don't have any restrictions. And I don't give them any post-op drops. I will say though, check their pressure. Give it for the first few sessions, try to check the pressure within a couple of weeks, especially if it's a post-YAG capsulotomy patient with an amorphous cloud, because I have seen very rarely patients come back with pressure spikes. So if there's a glaucoma patient, I'll check them within a week or 2 to make sure that the pressures are okay. And I'll keep them on anti-glaucoma meds. If they have a risk of glaucoma or risk of ocular hypertension, I'll put them on a topical drop like a Timolol or a Combigan or Cosop or whatever those drops, just to keep them until I see them next time. Again, very rare, but that is the one adverse event that I have seen once in a while that I want to make sure that you're all aware of that can happen. Dr. Biswas, have you seen any pressure spikes yet in your cases?
Not yet with the small number of cases that I have done. I wanted to ask you, what is the percentage of patients in which you have found IOP spike?
Yeah, so still less than 1%. I mean, we're talking about a handful, but I have had a couple where I've gone up to about 40, 50, and 60 even in some cases, but they're all the same type of patient, not for a Weiss ring. I've never, out of the thousands and thousands I've done, I've never had a pressure spike from a Weiss ring. It's always been the patient who had amorphous, larger amorphous diffuse clouds that are behind the lens. So especially a pseudophakic patient. And the theory again is, we think that as you're breaking up those particles and vaporizing, there's some small submicron particles that are coming around to the anterior chamber through the capsule in blocking the TM. And like a pseudoexfoliation kind of a situation where they have a sudden spike. SLT works very well, by the way, if that does happen, if drops don't work. So I would just be careful on those patients, but otherwise very rare to have a pressure spike. But I want to make sure people are aware, just to be fair and balanced, that it can happen.
Well, there is another question, Dr. Paul Singh, as to how long do you follow up these patients for possible complications? I do for 3 months. How long do you do?
Yeah, I think it's, well, we have a lot of studies going on. So I follow these patients in general. I have about 5-year follow-up on many of these patients. But I think, yes, I think if you look at data, after 3 months, the risk of the actual procedure causing a problem is going to be very, very rare. So I think if you have a good 3-month follow-up, like a cataract almost, you should be able to feel comfortable that you've done nothing to harm the patient. IOP spikes will happen within the first month. Inflammation we do not see. And so the only long-term risk you're going to be worried about is a retinal tear detachment. And again, after 3 to 6 months, it's hard to say what would be the cause of that. Again, the cause of a detachment is traction, right? That's our fear, traction. The one thing that's nice about vitreolysis based upon in vitro studies, as well as our, in vivo ultrasound studies, is we do not see a large disruption of vitreous, and we don't see pulling. We do not see traction on the retina itself. Now, are we changing the vitreous distribution of collagen? In other words, remember, the reason why floaters form is because the collagen fibers, right, have a negative charge around them. We have hyaluronic acid that covers them, and we have a depolymerization. We lose a negative charge of hyaluronic acid around those fibers, so they clump together and push water out. So there's a lacunae of liquid vitreous where we're firing these floaters. So that's why the floater may move. The floater may move because the vitreous is liquefied, but the actual disruption to the collagen fibers surrounding the floater is very minimal. So the long story short is I don't see a lot of risk after 3 months. So I think if you have good 3 to 6 month follow-up, I think you should be very safe.
Is there any age group restriction to this procedure?
I will say younger patients could be more difficult. Not that you can't do it, and it's not that because they don't have a PVD. I have done it with people who do not have a PVD, and I tell them ahead of time that this laser may induce a PVD, but I tell them it's more the type of floaters they have. Younger patients tend to have very thin, wispy strings and dots that are very hard to A, identify, but B, hard to truly vaporize. So if they have a solitary opacity that I can see and that it's very clearly causing their symptoms, I still would do it in a younger patient, even if they do not have a PVD. But I let them know ahead of time that they will develop a PVD eventually, whether it's because of the laser or not, we don't know. But I always let them know ahead of time. But I will be careful because of the type of floater that younger patients tend to have. How about you, Dr. Biswas? Do you do younger patients as well?
No, I have not. Below the age of 30, I have not taken up. I had a couple of patients below the age of 30 who came to me with complaints of floaters, but I could not detect any significant floater in all the examination techniques and procedures that I did. So I was foxed as to why they complained. I mean, I'm sure you or everybody else must be getting patients like this. Do you have any explanation for that? I mean, what for the patient complaining of floaters in the absence of a perceptible floater?
I will tell you, that's a very good point. So what we have found is using, we've had some high-speed ultrasound and high-speed swept-source OCT giving us an en-face view of the vitreous. And what's amazing, and these are some of the research scans that we have. And what we found is that there's a number of patients who have clinically significant floaters that we cannot see, but they actually are there. So our ability to identify them is actually the issue. It's not that they don't have them. And also it depends on their neuroadaptation. So I think it's a combination of the patient's ability to neuroadapt, their awareness of floaters, and our ability to see a lot of these thinner fibers. So I think they're there. It's just hard for us to identify those. But if you look at en-face OCTs that look at the vitreous, you'll see a number of these patients who have floaters that we cannot see actually have them. We're just not able to identify.
Okay. Great.
Well, I know we're over the time slot, but I wanted to make sure, did you have any other thoughts, Dr. Biswas? I mean, fantastic presentation. Thank you for your clinical pearls as well.
Well, you are the master. You are the master, and you educated all of us and many other listeners. Thank you.
Thank you, both of you, doctors. It's been a very illuminating talk. We have come to know a lot of things, even as people who are marketing this product. A lot of insights will help us to educate our customers better. Thank you for these insights. I'm sure our viewers also appreciated the clinical insights that they got. Thank you very much. Thank you, viewers, for your patience, for your participation. And thank you both, Dr. Inder Singh and Dr. Amitava Biswas, for making this evening wonderful. I think we have one more polling question, I believe.
Yes.
And that should be the end of the session then, please, with the pollings.
Shall I read it out? Would you like our representative to connect with you for the details? Okay, that's a question from your end.
Yeah, please send me a brochure and call me. I want to know more about the procedure. I would like to have a budgetary quote. So please submit this in the next 20 seconds.
Shanaz, if I can say one thing before we end, I just want to encourage everybody out there, even if you decide that you do not want to adopt laser treatment at this time, don't ignore them. I had a patient, I wish I don't show a lot of video testimonials, but I had a patient yesterday who I saw post-op. She was a pancreatic cancer patient who had been to 5 other doctors. She's been told she has a year to live. Vitrectomy, she has bad floaters. They wouldn't do a vitrectomy for her because of her history of her disease, and she was miserable. Well, I did one session on her. She came in crying because she said, for the rest of my life I have left, I can actually see better now. And I wanted to always be aware that just don't minimize the impact that floaters have on patients' quality of life. If you decide you don't want to do laser treatment, that's fine. We respect that. Even vitrectomy, if you don't want to do that. But these patients are suffering, and it's more than just saying, too bad, leave it alone, get used to it, because some of these patients really do have an impact in their daily life.
Absolutely, you're quite right, yeah.
I did this procedure on a scientist last week, and he was so happy and thankful because he was having difficulty doing his laboratory work and reading and writing, and he was feeling relieved.
Wonderful.
Yeah.
This is so gratifying. This makes everything worthwhile. Thank you. So
Okay.
thank you, everybody. We call it a day. Good evening to viewers in India, and good morning, Dr. Paul. Have a nice weekend, everybody.
Yeah.
Thank you, everyone. Be safe, healthy.
Yeah.
Bye-bye.
Bye-bye. Good night. Sachin, you can call the meeting off.